Assalamu alaikum. In this lecture, we will assess the tubular function as a part of the renal function test. In the previous lecture, we learned how to assess the glomerular function, while in this lecture, we will learn how to assess the tubular function. The objective of this lecture, we will list the test and know about how to assess the proximal tubular function and also the distal tubular function test. What are the characteristic features of each of them, and how can we interpret the result of the test performed as part of the renal function test. Also, we will know about the urine concentration test and the urine acidification test, and how can we interpret the result in each condition. And we will state the Eurymic Syndrome, what are the biochemical characteristics of this syndrome and the significance of it. As a reminder, there are three physiological processes occur in the kidney. These are the glomerular filtration, the tubular reabsorption, and the tubular secretion. The glomerular filtration occur in the glomerulus, in which all solute except for protein, large molecular weight protein, are filtered by the glomerulus, while in the tubule there will be reabsorption of most of these solute in a process called tubular reabsorption, and then there will be adjustment of the composition and the volume in this process, and the opposite process, which is called the tubular secretion, in which there will be secretion of the waste into the kidney tubule. The details of this process, I'm sure you have been taking it in the physiology lecture. This is just a reminder. We have three main processes: glomerular filtration, tubular reabsorption, and tubular secretion. The function of the proximal tubule is mainly the reabsorption of the bulk of the filtrate material, and this occurs according to the need of the body. And while after reabsorption that occur in the proximal tubule, the distal part and the collecting duct mainly is for fine adjustment. It is for the regulation of the hydrogen ion balance, and also for the creation of the fine adjustment of the electrolyte concentration and water balance. In the proximal convoluted tubule, most of the cell-free and protein-free filtrate that contain waste product, and usually this filtrate contain waste product which is very toxic to the body if it's higher than the normal, and in addition it contain very valuable material in this filtrate. So the function of the proximal tubule is to return the bulk of each important and valuable substance back to the blood circulation. So in the proximal tubule, the bulk of the important and valuable substance were returned back to the circulation by the process of reabsorption. About 75% of water, sodium, chloride, 100% of the glucose, almost all of the amino acid, the vitamins, and protein, and variable amount of the urea, uric acid, and urea ions such as magnesium, calcium, potassium, bicarbonate, all are reabsorbed. About 98 to 100% of the uric acid is actively reabsorbed in the proximal tubule. Then next, some of the substance, for example, the uric acid, will be secreted in the distal end of the proximal tubule. So the bulk of the reabsorption occur in the proximal tubule, while the function of the distal tubule is to effect small adjustment to achieve the electrolyte and acid-base homeostasis. and this occurs under the control of two important hormones, which is the antidiuretic hormone and the aldosterone. Antidiuretic hormone mainly for water reabsorption, and the aldosterone mainly for sodium reabsorption. And in the collecting duct and the final site, it is a final site for either concentrating or diluting the urine. The hormone, antidiuretic hormone, and the aldosterone act on the collecting duct of the nephron to control the reabsorption of water and sodium. This is a brief about the main function of these organs, of these different segments. When we suspect that this patient has defect in his tubular function, the disorder that it come in mind, it may be he is unable to concentrate urine, so he produces large amount of urine and with low osmolarity. Also, he's unable to produce acidic urine in a degree that is appropriate for his body pH. So he is unable to concentrate urine, he is unable to excrete acidic urine, and in addition, we suspect he may have impaired in the reabsorption of the valuable material that must be absorbed in the proximal tubule, for example, the amino acid, the glucose, the phosphate, and other material, so they will appear in the urine in large quantity. These defects either occur all together or may occur singly. For example, he may have defect only in the secretion of amino acid, or he is unable to produce acidic urine, or he may be unable to concentrate urine, or all these defects may occur together. And these defects either congenital or may be acquired secondary to disease that occur later. Most commonly, we test for the concentrating power of the renal and the ability of the urine to produce an acidic urine. If the glomerulus is functioning normally, then the defect was only in the tubule, the renal tubule, then the main defect is in the composition of the urine, because the process of tubular secretion and reabsorption occur in the tubule. So if we have defect in the tubule, the composition the valuable material are not reabsorbed back to the body, and the waste material that are normally excreted to the urine are not excreted. And in addition to the composition, the volume of the urine also may be affected. There will be excretion of large quantity of the urine, large volume of the urine. So it is better, because each segment of the tubule have different function. So the proximal is mainly for the reabsorption, while the distal for the fine adjustment. So it is better to test each of these segments apart. So we have certain test that is special for the proximal tubule, and we have a test for the distal tubule. What happens if the damage is mainly in the proximal tubule? For example, maybe any defect, maybe metabolic, obstructive, hypoxic, oxidative damage that occur to the cell of the proximal tubule. If they are distorted, what we will expect? First of all, the isoosmotic water reabsorption will be impaired. In the proximal tubule, we have about 70 to 80% of the water that is filtered from the glomerulus will be reabsorbed in this part of the kidney. This is equal to about 140 to 160 liter per day. So this isoosmotic water reabsorption is responsible for reabsorption of about 140 to 160 liter per day. It means that the active solute reabsorption from the filtrate is accompanied by a passive reabsorption of an equivalent amount of water. So the active reabsorption of the solute For example, the glucose and other material, other glucose, amino acid, and other will be accompanied by passive reabsorption of equivalent amount of water. This will be impaired if we have a proximal tubular defect, and normally the fluid, because of this process, which is normal, the fluid that enters the lumen of the loop of Henle is very much reduced in volume, because about 70 to 80% of the fluid is reabsorbed, but it is still almost isoosmotic. If we have damage to the proximal tubule, this process will be defective. The other process that will be impaired if we have proximal tubular defect is the counter-current multiplication, which is an active process that occurs in the loop of Henle, in which a high osmolality is created in the renal medulla. A high osmolality is created in the renal medulla, and the urine osmolality is reduced because of the high osmolality of the renal medulla, so the reabsorption of water occurs, and the reproduced urine will be of low osmolality. This process also will be impaired, and the ability to respond to the antidiuretic hormone also will be impaired. As a result, there will be production of large amount and large volume of inappropriately urine, which is diluted. So the large amount, large volume of fluid will be lost from the body. The other defect is that the reabsorption of the most of the solute that occur in the proximal tubule will be affected, and mainly we have the reabsorption of the phosphate, the glucose, the magnesium, the potassium, the urate, the amino acid. The reabsorption of these substances, which are very valued, will be affected, and it will be impaired. In addition, the ability of the tubule to secrete hydrogen ion will be defective, it will be impaired, and as a result, the reabsorption of bicarbonate also will be impaired, because these processes are closely linked, because they cannot secrete hydrogen ion, so that the reabsorption of bicarbonate is also defective. As a result, the urine will be alkaline, and this will be inappropriate for the pH of the body. If we want to take a blood sample and test for the finding in this condition, we will find that because the glomerular is normal in this condition, then the plasma urea and urea and creatinine concentration will be normal, because it is a function of the glomerulus. There will be a decrease in the level of the potassium in the blood. There will be decrease in the level of phosphate in the blood, hypophosphatemia. There will be decrease in the level of magnesium in the blood, and there will be decrease in the level of uric acid. And the bicarbonate will be also low, because it cannot be generated and are reabsorbed. And there will be also the low pH. We have hydrogen ion cannot be secreted, so there will remain in the body. And as the hydrogen is cannot be secreted, there will be acidosis in the body. And since it's not of a respiratory cause, and it's accompanied by low bicarbonate concentration, we call this type of acidosis metabolic acidosis. These are the findings in the plasma. What about the finding in the urine? In the same condition, in case of proximal tubular functional defect. In the urine, because we say that 70 to 80% of the water is reabsorbed in the proximal tubule. So in case we have there's defect in the proximal tubular cell, there will be increase in the volume of the urine. There will be polyuria, and also the pH will be alkaline, tending to be alkaline, inappropriately high. And because the tubule cannot secrete the hydrogen, because the tubule cannot reabsorb the phosphate, there will be increase in the phosphate concentration in the urea. This is called phosphate urea. The tubule cannot reabsorb glucose, so there will be glucose urea. While in the circulation we have low level of these analyte substance, and uricosuriia, which is increase in the concentration of the urate in the urine, and decrease, it will be accompanied by decrease in the blood level of urate, and there will be increase in the secretion of amino acids in the urine. It is called generalized amino acid uria, and there will be in the circulation in the blood, there will be decrease in the level of amino acid. This was about the proximal tubule. What about the defect that occur in the distal tubule? In the proximal tubule, the main defect was in the reabsorption, in the isoosmotic water reabsorption. It affects the counter current multiplication. In the distal tubule, mainly the defect will affect the acidification of the urine, which is the production of an acidic urine. This acidic urine is the result normally of the excretion of hydrogen ions that result from the metabolism of the volatile acid. Normally during metabolism, there will be production of a volatile acid as a byproduct, so the body tends to remove them by excreting the hydrogen ion in the urine. This process will be defective in case the patient have a defect in the distal tubule. In this condition, and since there is defect in the urine acidification, so the urine pH, when we test it, we found that it never fall below 5.5. Another defect is the failure to respond to aldosterone. Aldosterone is a mineralocorticoid that is secreted from the secreted from the adrenal cortex. It is responsible for reabsorption normally of the sodium. So there is in this condition, the aldosterone response to aldosterone will be impaired. So there will be no reabsorption of sodium, and the urine contain high concentration of sodium. In addition, if we take blood sample and test for the bicarbonate, we will find that the level will be low. Chloride will be high, and the pH also will be low. This is called hyperchloroic acidosis because the chloride is high and the pH is low. The pH is low because it cannot be secreted. The hydrogen ion cannot be secreted. In addition, we will have hypokalemia. In the urine, also you have increased volume of the urine because of the defect in the reabsorption of the water that occur in these segments. And there will be defect in the acidification, so the pH will be inappropriately high, tend to be alkaline. And because of the inability to respond to aldosterone, the urine contain high concentration of sodium, and there will be the low urea concentration. And because the urea concentration is low, as a result, the osmolality also will be low because the osmolality depends on the number of the solutes. These are the findings in case we have distal tubular function test defect. These are the tests that will be performed if we suspect that any patient have distal tubular function defect. Other tests in case of suspected distal tubular defect is the water deprivation test. The production of a concentrated urine depends on two factors, which is a normal tubular function, which is able to reabsorb the water, and the presence of an hormone, a peptide hormone that is secreted from the pituitary gland, which is the antidiuretic hormone, which is responsible for reabsorption of the water. So we need two factors. We need normal tubular function, and we need a normal concentration of antidiuretic hormone. So if we have defect in the, if we want to test if there is defect in the distal tubule, we can do the water deprivation test. If we have a defect in the result of the water deprivation test, either of these two factors may be defected. Either the tubule is not working properly, cannot reabsorb the water, or there is no antidiuretic hormone, or the response to antidiuretic hormone is defective, so that the reabsorption cannot be performed well. So we have two factors. Two of them must be properly working to achieve a normal concentrated urine. Urine osmolality is a test to measure the number of the dissolved particle per unit of water in the urine. How many particles are found in a unit of water in the urine? It is a measure of the concentrating ability of the kidney. The urine osmolarity is more accurate than the specific gravity, but both of them are closely related, so we can measure the urine specific gravity as a direct estimate of the osmolality. It depends also on the renal concentrating ability, and it is a function of the antidiuretic hormone. We can measure the urine osmolarity or the other indicator of the selective water reabsorption. For example, if we measure the urine sodium, also it can give an idea about the osmolarity, the urine urea, the urine creatinine concentration. Also, they have the same diagnostic performance. The urine osmolarity normally is between 50 to 1250 millimole per kg, so there will be a wide range and depend on the concentration and the dehydration state or the hydration state of the body. How can we know that the concentration ability of the kidney is working properly? By doing the fluid deprivation, and later on we can do after that test we can start with the Ddavp test, or giving the synthetic antidiuretic hormone, or what is called the synthetic vasopressin injection. This test include the deprivation of fluid in a patient over several hours, and we make sure that the patient is not drinking any fluid and there is no excess fluid loss, for example, by sweating or diarrhea that is abnormal that occur during this exam. So there be ask the patient to stop drinking water overnight, and then we collect the urine specimen and we measure the osmolality in the urine specimen. Normally, if there is normal tubular function and there is normal secretion and level of antidiuretic hormone and normal response to antidiuretic hormone, normally there is no increase in plasma osmolality, and the normal range is between 285 to 295 millimole per kg. During the test in a normal person with a normal tubular function and a normal level and response to antidiuretic hormone, their plasma osmolality will be stable, and throughout the test there will be no increase in the plasma osmolality, and the change occur in the urine osmolality due to dehydration, due to deprivation of water. The normal response is increase in the urine osmolality to more than 800 millimole per kg. This is the normal response if the tubule are normal, if the concentration ability of the kidney is normal, and if the level and the response to antidiuretic hormone, which is responsible for the reabsorption of water, is normal. The abnormal response occurs if there is increase in the plasma osmolality and the fixed urine osmolality, inability of the urine to be concentrated. The decrease, if the urine osmolality doesn't increase, it means there is failure to concentrate urine, and the cause may be either in the tubule itself or in the antidiuretic hormone. Maybe there is no response, the kidney doesn't respond to antidiuretic hormone in nephrogenic diabetes insipidus, or it may be already not produced from the pituitary, from the hypothalamic pituitary axis. There is no antidiuretic hormone, so it cannot reabsorb water. So we have two reasons behind the failure to concentrate the urine. If after the test of the defined time of the test of fluid deprivation, the plasma osmolarity increase and the urine osmolarity fail to increase, and this is an abnormal response. In this condition, we can complete the test by giving the patient a synthetic antidiuretic hormone to see where is the defect. We say that if failure to concentrate urine over this time more than 800 millimole per kg, if failed to reach this normal level, it means the kidney lost its ability to concentrate urine. The defect either is in the tubule, it cannot reabsorb the water, or the defect is in the hormone that is responsible for reabsorption of the water, which is the antidiuretic hormone. So we give the antidiuretic hormone, which is synthetic vasopressin, or it's called Ddavp, and we collect urine sample for over 3 hours. And in each of these urine sample, we measure the osmolality. So we give something that enhances the reabsorption of water. In this condition, we expect that the osmolality must increase if the defect is in the antidiuretic hormone. How can we interpret the result of the test? If the patient have a tubular defect, the defect is in the renal tubule. In this condition, the tubule cells are defective, so they cannot reabsorb the water. And in addition, even if we give injection of the Ddavp, the vasopressin, the antidiuretic hormone, also it have no effect because because they are damaged, they cannot respond to the antidiuretic hormone. If the defect is in the renal tubule, the cells are damaged, so they cannot reabsorb water. The water will appear in the urine in large volume. And in addition, even if we give the synthetic ADH, the vasopressin, even if we give, the cells are also defective and they cannot respond to it. And in this condition, the result of both tests are negative. And the result will be the plasma osmolarity increase and the urine osmolarity failed to increase for both tests. But if the patient have polyuria increase in the urine volume due to hypothalamic pituitary origin in which there is defect in the production of the antidiuretic hormone, the hormone responsible for water reabsorption, then if we give him a synthetic vasopressin or antidiuretic hormone, the Ddavp, then there will be an increase in the result is that during deprivation test, fluid deprivation test, the plasma osmolarity increase. But when we give him the Ddavp, the vasopressin, we will find that the urine osmolality will increase. This is the difference between how can we differentiate between them is in the Ddavp test. Both of them have lost their concentration ability, but one of them due to defect in the cell, in the tubular. If the defect is in the renal tubular cell, the cell cannot reabsorb water and cannot respond to the antidiuretic hormone. And in both conditions, the plasma osmolarity increase. And in both tests, the plasma osmolarity increase and the urine osmolarity will not increase. While if the defect is due to a decrease in the production of the antidiuretic hormone due to hypothalamus or pituitary defect, in this condition, the fluid deprivation test also show increase in the plasma osmolality and no change, and the urine osmolality doesn't increase. While if we give the synthetic vasopressin in the Ddavp test, the urine osmolality will increase in this condition if the defect is in the diabetes insipidus of the hypothalamic and pituitary origin. The other important test is the urine acidification test. The urine is usually acidic, and one of the function of the kidney is to get rid of the excess of the hydrogen that result from the metabolism by excrete it in the urine. So it is in healthy individual, the urine is acidic. And the acidification and secretion of hydrogen usually occur in the distal part, mainly, and the fine adjustment usually occur there, and there will be reabsorption of a bicarbonate. Bicarbonate is the basic compartment, while there will be excretion of the hydrogen, which is the acidic compartment, and this will result in an acidic urine. If there is defect in the acidification power of the kidney due to damage to the cell, then of the renal tubule, and then the urine that is produced will be not acidified to a degree proper to the need of the pH of the body. So we will test it. We take a urine, which is fresh urine, and we test for the pH. We can test it by using dipsticks that are specific for this purpose, and it can give a rough estimation, and not very accurate. It can give a rough estimation of the urine pH. If we have defect in the kidney, in the tubular function of the kidney, the urine pH will not be acidic in this condition, or not proper for the pH of the body. But we must put in mind that we have certain condition in which there is no defect in the kidney, but still the urine is alkaline, for example, in the vegans, or in some case of urinary tract infection, also the urine will be alkaline. So we must exclude these two conditions before we judge that the acidic urine is due to failure of the acidification power of the kidney. We can do more sophisticated tests by giving the patient ammonium chloride, and we test the urine pH. And usually after we give ammonium chloride load, usually the pH decrease to less than 5.3. If we take many samples, at least one of these samples, we have the pH decrease to below 5.3. In addition, we have more tests to define where is exactly the defect or the acidification defect, either in the proximal or in the distal part of the tubule. This was all about the testing the distal tubular function as part of the renal function test. Then we will have another subject, which is the Uremic Syndrome. The Uremic Syndrome results from failure of the kidney to maintain adequate function, whether these functions are regulatory function, and excretory function, filtration function, endocrine function. So the azotemia or uremic syndrome, the other name is the synonym is the azotemia, uric syndrome, or azotemia. It means inadequate function of the kidney, whether excretory function, regulatory function, and endocrine function, and all of the function may be defective. What happened in this condition? How can we know that this patient have a uremic syndrome or azotemia? There will be, if we measure a blood sample, we will find that there is increase in the blood urea, increase in the blood creatinine, increase in all nitrogen end products of amino acid and protein metabolism, all that are normally the body excrete them in the urine. In this condition, their concentration in the blood will be increased. Why? Because of a failure of the kidney to excrete them, so they will accumulate in the blood. This is called the uremic syndrome. What are the biochemical change that occur in the uremic syndrome that can characterize this condition? The first and the most characteristic is the retained nitrogenous metabolite. We have the certain analyte that result from the are considered as the end product of the nitrogen metabolism. We have the urea, the creatinine, the uric acid. All these compounds normally is excreted in the urine, and the blood level are maintained within a very narrow limit. In case we have uremic syndrome, the concentration of these analytes are increased. The other things is that the acid-base balance, the electrolyte concentration, and the fluid balance all will be affected. Why? Because the tubular function also will be defective. The reabsorption, the secretion, all will occur in the tubule. So the urine osmolality will be fixed, Normally, the urine osmolality must be changed according to the hydration state of the body, and the urine osmolality depends on the concentration ability of the kidney. The reabsorption depends on the osmolality, depend on the number of the solute that's present per unit water of the urine. So if there is decrease in the production of the excretion of the sodium and other urea and other analyte, there will be a fixed urine osmolality or even a low urine osmolality. There will be metabolic acidosis. Why? Because failure to excrete the hydrogen that is found as a result of the normal metabolism and failure to excrete this hydrogen in the urine, it will be remain in the body and result in acidosis, and failure to reabsorb the bicarbonate, which is the basic compartment. Failure to regenerate bicarbonate result in the metabolic acidosis. The nitrogen, the sodium balance will be defective. There will be either hyponatremia, which is the decrease in the sodium, or hypernatremia, which is increase in the level of the blood sodium. This is applied also for the potassium. There may be either increase or decrease in the level of the potassium. The calcium will be decreased because of the production of the vitamin D, the active form, occur in the kidney, the final hydroxylation step, and the production of 1,25 dihydroxy vitamin D occur in the kidney. So if there is a defect in the production of vitamin D, there will be hypocalcemia. Also, the parathyroid hormone will be affected, and hyperphosphatemia also occur, and hypermagnesemia. The uremic syndrome also affect the carbohydrate metabolism. There will be insulin resistant. Insulin resistant is the base of many diseases, including type 2 diabetes, include the obesity, metabolic syndrome, and many other diseases. The central obesity, all they have the insulin resistant play a vital role in the pathogenesis of these conditions. As a result of insulin resistance, there will be compensatory increase in the level of insulin, and there will be hyperinsulinemia. Also, the glucagon level will increase. So we have abnormality in the increase in the level of the waste nitrogenous product. We have increase in the level of the basic metabolite. The acid-base balance will be disturbed. The electrolyte will be disturbed. The fluid balance will be disturbed. The carb intolerance and carb abnormality also will occur. There will be abnormality in the lipid metabolism. There will be dyslipidemia. There will be increase in the triglyceride level, which is very dangerous, and we have decrease in the level of the protective, the good cholesterol, which is the HDL cholesterol, which is very good for the cardiovascular health. So when we have high HDL, it has a protective effect. In case of uremic syndrome, this protective effect will be decreased because of the decrease in the level of the HDL, the high density lipoprotein cholesterol. Also, there will be altered endocrine function as a result of the abnormality in the uremic syndrome. The main thing is the erythropoietin will be decreased because it is produced from the renal cell. So erythropoietin stimulates the production of RBC. If we have no stimulus, no erythropoietin, there will be anemia. There will be secondary hyperparathyroidism and osteomalacia, secondary to a decrease and abnormal metabolism of vitamin D, calcium, and phosphorus. The aldosterone may be abnormally increased or decreased, and as a consequence, the renin also will be abnormal. Gonadal dysfunction is also a cause. There will be decrease in the metabolism and the abnormal level of the gonadal hormone.